people who are being the resource persons for our session today, and one person who would be presenting the case. I'm really glad to invite Ms. Arathy Venukumar, who is working as our national coordinator with the State Facilitation Division of Palliative India. She has an MBA. She is an MBA graduate with specialization in HR and finance, and has an experience of more than 10 years in human resource management. She has been a part of the Pallium team for the last 7 years. Thank you, Ms. Arathy, for joining us, and welcome to the session. And the next person is Mr. Vishnu PR, who has been working with Pallium for the last few months, and he's working as a regional coordinator of the Southern region. He's working with the state facilitation team. He has done his master's in international business and has an experience of 10 years in the developmental sector. Previously, he was leading a youth climate initiative in association with the state government of Kerala. Thank you, Vishnu, for joining us. I hope Vishnu is with us. Yes. Okay. We have Sarat Krishna, Mr. Sarat Krishna, who is currently working as a social officer in Pallium, India. He has an MSW degree, and he has notable experiences in working as a community social worker, and he's also been working with certain tribal projects. Thank you, Sarat, for joining us. Welcome to the session. We have Ms. Deepa Jose, who has joined us. She has a master's in social work degree in medical and psychiatry. She has worked with Saki One Stop Center as a psychosocial counselor, and she has notable experiences in various other settings too. Thank you, Deepa, for joining us. So thank you all of you for joining us today. And without further introduction or any lag in the session, I'd like to move on to the session. Thank you. And over to you, Ms. Arathy or Sinia.
Thank you, Manisha. Good afternoon, all. Thank you for joining in. This is Arathy, this side. So we'll start with the presentation now then. Sure.
I'll just add one more thing, sorry. If anybody has any questions, please do feel free to put it up in the chat box so that we can answer during the discussion time. Thank you.
And I'm also requesting all to turn on their videos.
Is everyone able to see the screen? So once again, good afternoon all. Last week, we all got an overview on introduction to palliative care. We would like to start our session with that only, just to you are now aware. Sorry, one second. Yeah. Okay. Is it visible, right? Yeah. Okay.
Yes, it is. Yes, it is.
Yeah. Okay. Okay. So now you are now aware of the definition of health and palliative care. Even then, few things are necessary that needs to be stuck on into our minds, like health. So the moment we hear the term health, the first thing that comes into our mind would be any kind of physical condition. With the last session, you would have come to know that it's not only the physical condition that that comes with as a definition of health. It also includes mental and social well-being. So, and according to us at Pallium India, it would be spiritual aspects too, along with these two things. So now moving on to the definition of palliative care. So, okay, once, moving on to the definition of palliative care. This definition is given by World Health Organization, which you can read here from the slide. Ultimately, it's the improving of quality of life of the patients as well as their family, involving physical, psychosocial, and spiritual aspects. Now, the misunderstandings that always comes along with palliative care is that we have already seen in the previous slides. Like palliative care is end of life care, and for incurably ill patients. So no, it's not like that. Palliative care can be started from the point of diagnosis itself. And another misunderstanding that is associated with palliative care is only for cancer patients, and which is not. Palliative care is for all with serious health-related suffering. Now, we'll move on to a video which will, which will give you overview, a holistic approach of total pain. It's a talk by Smriti, whom you have met in the last session. We'll watch the video and come back. Over to the video.
In palliative care, we have this In palliative care, we have this notion of total pain, pain that takes into account the life circumstances of the patient that contribute to his or her experience of suffering. I came across that concept quite early in my life, and I mean, in my career, and I thought I understood it, theoretically at least. And then one day, the home care team that I was a part of was called in to see this fisherman in one of the outlying villages of Trivandrum. We parked our van some 400 meters away, made our way down this narrow, undulating path. We could hear this man's screams well before we got to his house. And on approaching the house, we were assaulted by the stench, which made me gag. And when we entered his home, we were met by this helpless young woman, and behind her on the bed, a man in his 40s, who was the source of the screams. He had a myriad problems and a feeding tube. And on closer examination, we found that he also had a bowel obstruction that was not allowing him to pass what his wife was so diligently feeding him because she didn't know what else to do to look after him. And as a result, he was regurgitating his own waste. It was awful. Anyway, he was cleaned up, analgesics and other medication were administered, but no matter what we did, his pain would not fall below 6 on the pain scale, which is essentially a scale of 1 to 10, 10 being the highest, where we ask people to score their subjective pain. So finally, this benevolent and wise doctor that I have the absolute privilege of calling my mentor, he took this man's hand in his own, and he asked him, he said, "What's your biggest concern right now? What is bothering you?" What an odd question, I thought. I mean, the pain, the humiliation, the despair, and just the misery of everything that he was experiencing. I mean, the answer was glaringly obvious to me. The man didn't say anything for a long time, and I started to get fidgety. The silence was starting to get awkward and strained, to me at least. But the good doctor, he held steadfast. And after about 6 long minutes, and I know this because I was timing it, this man very softly said, "All I wanted was for my children not to be fishermen. And now they're going to be just that." He knew he was dying, and he knew that his wife would not be able to support the children on her own, and this one fact was causing him far more agony than anything else that he was going through. So one of the things we strive to do in our program is to undertake the educational needs of
So, am I audible now?
Yes, you are.
Yeah. So now you know that it's not just physical pain that matters. This is what that matters as in palliative care. So now hope you are getting the connect. By seeing the video and what matters and all. So now moving on, how to deliver palliative care in Indian context. So as you can see here, delivery can be done through outpatient units, inpatient facilities, and home care. Beyond that, we can have hospices too. And halfway home here, that is rehabilitation halfway home here, is a specific project that Palliative India has. This is a rehabilitation project that Palliative India does for spinal cord injury patients. So in home care, as I mentioned, the way of the delivery that we happens in palliative care, like how delivery happens in palliative care, we have seen home care too. So in home care, we have here at Palliative India, we have 5 to 6 teams going on for visits every day, and they carry medicines and consumables, whatever the patient may require for their care with them, and they reach to the patient where they are. That's what the concept is. Home cares, the concept of home care is, and during the home care, we try and make the family empowered. Like for example, if the patient has a wound, and we cannot go and dress every day. So we empower the family or the caregiver who is or the direct caregiver who takes care of the patient. We help them, we empower them, we train them how to take care of the wounds, and that's how it happens in the home care. And that's how we ensure that patient is having a continuous care. Another thing that goes into delivery of palliative care is community mobilization. Here we do a mobilization of from the community, the volunteers, specifically. Sorry. So sorry. The another strong pillar, that's what I was trying to tell. The another strong pillar that happens in palliative care delivery is community mobilization. We find people who are interested to work in community or work in palliative care, and we create groups of these interested people, and they then continue the care for the patient or the needy. There are different aspects in which volunteers help us. Before that, this is the concept that we follow, like in community model, like acting as a bridge between the micro segment and the macro segment. That's what we follow. And the main element of this social capital will be the volunteers. So, and the volunteers help us in these things. They help us in community support. They help us in palliative care. They refer patients from the community because they know them better. And we help them, and through volunteers, we do social supports. They help us in advocating about palliative care to the public. They help us in raising funds. And of course, if they are not interested in patient care, they will help us in clinical works that happens at the center. not specifically Palliative India, it can be any center or any hospice where these volunteers are involved in. Another programs that we do based on community programs that we run in Palliative India. Specifically, this is specifically this is for Palliative India. We have students initiative in palliative care, wherein we have young people. They may be students, they may be working professionals. So this is specifically to the students. So students initiative in palliative care, we have collaboration with universities, Kerala universities, wherein they have a specific group called SIPC, wherein they are into palliative care. They volunteer for palliative care. We have groups called compassionate community care. These are small groups, maybe from the residents association or some social group in the society. For example, like Lions clubs, Notary clubs and all. So we have people who are interested in palliative care. So they form a group called compassionate community care. And we have Kutikutam summer camp. This is a group of students, children of patients who are under our care, whom we provide education support. We bring them together in the month of May, like summer camps. They have a residential program for three days, and they stay with us. They have career guidance programs, mentorship programs, and all. So that happens during the Kotikutam summer camp, and this is led by the volunteers at Palliative India. And we conduct awareness programs in the society, sensitization programs. We have events like death and dignity with life and death with dignity. And we arrange for fundraising events also at Palliative India. So this is an overview of how palliative care delivery happens. And now we'll have a video, one more video going on, and then we will have a brief on how it is done done by Palliative India here. So next we'll have a video.
Ashla is my
Good afternoon, everyone. I'll take it from here. My name is Vishnu. As said earlier, I'm the regional coordinator handling South Indian states. I'm also part of the state facilitation division here. So you have just seen the quality of life video by Ashla, our dearest Ashla. She's always an inspiration for all our staff here in Palliative India. She's now a trustee, came as a volunteer in Palliative India. Now she's the trustee of Palliative India Trust, one of the trustees in Palliative India Trust. So, yeah. Okay, so as Arathy said earlier, WHO has, as per WHO, World Health Organization, these are the three components required for a palliative care delivery to be successful model: education, drug availability, and policy and implementation. So as you see, this is all these components are really interconnected to each other. If one's get compromised, the whole system gets affected. Coming to the education part, we always focus three types of people for educating and creating awareness. One is the medical professionals. Second, administrators or the bureaucrat. Third, the layman, the common public. So even if there are medical professionals in this group, even you people might admit the fact that even the medical professionals are a little bit unaware about what exactly palliative care is. So the lack of awareness is the main issue there in delivering the palliative care, especially in the Indian context. Second, regarding the bureaucrats and administrators, even though the laws are made, laws are on papers, it's really difficult to get implemented on the ground. So conducting awareness program, training programs for bureaucrats in state-wise and in the central scenario is one of the component of education. Third, basically, we have to create an awareness and consciousness among the public that what exactly is the palliative care. The patient and family, the caregivers are the real focus of the palliative care domain. So education is one part. Second is the drug availability. You all know that pain relief is one of the backbone of palliative care. Pain relief drugs like morphine, methadone, and fentanyl are the key components for for drug availability or opioid availability. Opioid accessibility and availability in India for the last many generations is really in bad shape. So if a palliative care service delivery to be successful, drug availability is one of the key integral components for that. Coming to policy and implementation, there are basically two policy sides. One is the government policy and the institutional policy. Government policy, we have many policies ongoing associated with the palliative care domain. The most recent amended domain was the National Narcotic Drugs and Psychotropic Substance Act. It was a rule came in force at 1985. There were many issues with that. It was amended due to the support of civil society groups and other individuals. It was amended in 2014 and new rules came in 2015. So such efforts also are required as part of the advocacy triangle, specifically in the palliative care delivery focus. So as per WHO, these are the three major components. If you are interested in starting a palliative care service, or if you're part of a palliative care delivery domain, you should be in this context, in this particular context, to start the palliative care service, considering these three components. Moving to the, again, in Indian context, as Arathy mentioned earlier, inpatient, outpatient, and home care are the major delivery aspects of the palliative care, but those are delivered in these three aspects. First one is the standalone or the hospice, basically a palliative care center. Second is the department, a palliative care department or a unit within an established hospital. Third is the community-based home care. Standalone hospice, basically palliative care center and a hospice keyword. The terminology has a narrow difference. Hospice came, from my understanding, hospice came from a Western context, basically providing quality, increasing quality of care, doing the symptom and pain control there. Basically, patients, palliative care patients will be there for more than 3 months, 6 months, longer period towards the end of their life. That's the hospice culture basically means. A palliative care, a standalone palliative care center. A department within a hospital, again, if you want to start a palliative care department within a hospital, you have to connect with the leadership of that institution. You have to understand what's the revenue model of that. You need to understand how the patients are being referred there. So within that model itself, there are government, charitable, sustainable, and for-profit models. Even though the delivery model is same across all these formats, the operational flow is completely different. For example, government, it's really difficult to get a permission to get an infrastructure for starting a palliative care unit within that hospital. Charitable, sustainable is more kind of a subsidized rates. They are not profit, like they charge patients in a very subsidized rates till that unit gets sustainable on its own. That's the sustainable model. And the for-profit, So for the last couple of years, we are seeing a great demand among the young doctors, especially palliative care physicians, with this for-profit model. So it is a changing scenario. More and more for-profit palliative care models are coming in the Indian context. Coming to the third, community-based home care. So if you see the first two models, home care is always integrated with the palliative care delivery. But community-based home care is a bit different, especially in Palliative India is one of the community-based charity model. So we are providing the home care services, just not sending our clinical team to the patient homes. Rather than we first connect with the community there. We always try to do awareness campaigns and training orientation in that particular community before starting delivering the services. We try to find a local champion, a volunteer, a community volunteer from within the community itself, so that he or she can identify the patients nearby within the community. They can identify the challenges there, especially the social and cultural context within that community. Once they identify, they point out these are the patients there which needs palliative care. Then we send the clinical team there with an holistic approach and integrated palliative care approach. That particular volunteer, community volunteers, they own it up. They take the responsibility to provide palliative care. Palliative care delivery happens in a holistic manner without having a much dependency on the system side. So that's the, so far, Palliative, as an organization, Palliative India suggests this model of palliative care delivery. So this is the examples of some of the models like standalone hospice. You can see the Sipla Palliative Care Training Center. Our team is visiting there. It's in Mumbai. Ruma Avedana Hospice, and I think it's West Bengal. Then Chandigarh Hospices. These are our team visiting our stakeholders. This is a palliative care department within a hospital. You can see the inpatient beds there. Basically, it's a normal department within a hospital. So coming to the community model, hope you have seen this slide in the previous session also. Community model, as Arathy said, we are seeing macro institutions getting bigger and bigger day by day. The established medical colleges and tertiary healthcare institution. And you can see the micro user, the layman, the patient and their family getting far more, the distance between both these entities are getting higher and higher day by day. That's where the component, meso component or the community component came in. Kerala as a state has really utilized it. I can go further and say it has exploited the power of community or the social capital, which Arathy mentioned earlier. You can see the social worker there, doctor, nurse, and the family of that patient, particular patient. So this community model is trying to bridge the gap between the micro and macro component within the Indian context. So as I said, Palliative India has a community charitable model. You can see on the right-hand side, demonstrate, educate, facilitate. These are the major operational model of Palliative India. Within the demonstrate, you can see the Trivandrum Institute of Palliative Science. So this is the flagship training center, a WHO collaborating training center for advocacy and pain relief. We, through all the facilities provided through TIPS, we call it as TIPS, through TIPS, whether it's inpatient, outpatient, or home care, or any research-based facilities. Any facilities provided here is kind of, we are depicting it as a demonstration site, kind of a prototype or a proof of model, so that our stakeholders from other states and abroad can come here, visit us, learn us, have a mutual learning process, then try to facilitate and replicate this model within their social context in their region. That's kind of the demonstrate model. So this is the Trivandrum Institute of Palliative Science. You can see the picture there. We provide their IP, OP, home care, other rehabilitation supports there. And these link centers, I'm not going into detail, but link centers are the backbone of the community-based palliative care, which I just now. So volunteers are the ownership, taking the ownership of those link centers. It's more kind of a makeshift OP clinic. They'll find a nearby public library or a school. They'll try to get the permission from the school authorities so that they can have an OP clinic, a daily OP clinic there, maybe on a weekend basis, on a weekly basis. They'll arrange the platform for us. They'll bring the patients there and we'll go there and treat the patients. Those patients who cannot come there, we'll go for the home care. So that's the link centers. We have around 14 link centers in Trivandrum district. Our headquarters is also located here in Trivandrum in the Kerala state. So this is a national helpline number. We have a telehealth provided by Palliative India in 4 different languages. Any palliative care beneficiaries, whether it's patient, doctors, or even emotional support if you want for your neighbors or close ones, you can call in this number. It's available on Monday to Saturday on the office hours. You can get the services through this telehealth consultation. It's available in English, Hindi, Tamil, and Malayalam. It's a national telehealth number. So going to the next model as an educate model, as you know, we have seen the triangle of the WHO advocacy triangle. Education is one of the major important. Not only the formal training, but also the awareness and the orientation of the palliative care stakeholders, whether it's public, medical professionals, or bureaucrats. We need to, there is a huge requirement for educating all these stakeholders in our system. So our academics division, TIPS, has a dedicated academics division doing virtual training programs, on-site training programs here in TIPS in Trivandrum. We also conduct on-site training programs at your region. If you are interested and if you are arranging for a training program in your region, we'll send our faculties there so that we can conduct an on-site training program at your place. So these are basically some of the program names. For doctors, we have FCPM, Foundation Course in Palliative Medicine. This is a virtual training program. Then it's CCPPM, it's an on-site training program conducting here in TIPS. It's a 6 weeks program. Then for nurses, FCPN, CCPN, I'm not going into detail, just mention all these details are available in our website. So kindly you can go through there. And allied healthcare professionals, it's Foundation Course in Palliative Care. That's the program which you people are attending now. This is for allied healthcare professionals and for any other people or any other experts in different domains who are ready to contribute in the palliative care domain according to their expertise. So this is the program which we are running now. For volunteers, it's volunteer training program for the general public. Then for the students, volunteers in colleges, students against needless suffering. That's the Sunscreen program. Then for palliative care beneficiaries, people with lived experiences, trying to do the advocacy programs. It's basically a support network. That's the Arohan program. For already palliative care physicians who have undergone initial training in palliative care, for them it's the RCPM, refresher course in palliative medicine, for an advanced kind of training. Going to the next stage of the facilitation. This is the part where I and Arathy are part of. State Facilitation Division is doing the facilitation here in Palliative India. So basically, just to give a brief facilitation, State Facilitation Division comprises of 6 people. We are categorized, our operations are categorized into 4 regions of India, North, Northeast, Central, and South India. I am handling the South Indian states. So if you are from any of these regions and if you are interested to do some of the contribution, like if you are a lawyer, if you want to do some legal work in palliative care domain, we can connect you to the existing our policy team or the legal team here. Or if you want to contribute as a volunteer in your area, we have several partners across the country. We have presence over 27 states and 3 union territories. We can connect you with the local palliative care stakeholders there. You can go and connect with them, try to understand what exactly are their requirements. If you want to raise some funds for them, you can do it. Or if you can if you have any expertise in specific domain, you can contribute accordingly. So we will be your first point of contact in those areas. If you, I think they will share the contact numbers of regional coordinators within the chat box, or you can find it in the Palliative India website. So according to your region, you can contact us anytime. We'll support you end-to-end in whole palliative care delivery, especially in the Indian context. So these are the objectives of State Facilitation Division. Basically, our philosophy is to integrating palliative care into mainstream healthcare. All 3 levels, primary, secondary, tertiary, we have to integrate palliative care in all its terms. So these are the 5 objectives: catalyzing new palliative care centers and services. As I said, we have almost 64 centers, palliative care centers have been catalyzed across the country. Again, government, charitable, sustainable, for-profit models. Then assist opioid accessibility in all regions and medical institutes. So basically, this is one of the core component of Palliative. Even though the laws are there, it's not, we have ground challenges. So as per the new amendment, there is a provision called recognized medical institution. That certificate is required by all palliative care entities, whether it's hospitals, NGOs, or any other groups. A palliative care facility needs to have that certificate to procure, stock, and dispense and prescribe essential narcotic drugs which are used for medical purpose, like morphine, methadone, and fentanyl. Those are the really needed. Since there are many complexities within that law, that's one of the core objectives of state facilitation. We work with the state drug controllers in states and other central officials in the center, so that more people in pain needs, or they are accessing these pain medicines at the right time. Enabling palliative care learning in medical institutes. So till 2019, we didn't have a palliative care module or an integrated module within the MBBS or curriculum or the medical students curriculum. So after 2019, we had a wonderful, as a start, it's not a complete palliative care module, but as a start, we have a palliative care teaching happening on MBBS now. So trying to approach the private medical universities, medical colleges, and government institutions to customize their modules as per the new provisions. That's one of the core objectives. Building up the community engagement and volunteer mobilization. This point is really connected to the participants, which you are you people, because after this training, we will be contacting you how you can contribute to your palliative care domain within your region, or you can come here and help us. So we'll be contacting each one of you. This due to the time constraints, we are not able to provide more details on that. But once the training is completed, we'll be in touch with you how we can go forward as per your interest. Because competency and compassion should go along. That's the only way to provide quality palliative care delivery. Just because you are passionate about palliative care doesn't mean that you can contribute in a more quality way. So you should have an equal, each of us are very good or expert in some of the domains. So we should identify that domain first. So, and integrate that competency within the palliative care structure. So we'll be in touch. We'll do that in your region, mobilizing the community and volunteers in your area. Developing pain-free hospitals by eliminating serious health-related suffering. So this is in a very infant phase. any patient walking in a hospital will be assessed based on their pain scores of a 1 to 10, 10 being the highest. So that's the pain-free hospital concept. It's a new concept. We are in touch with a couple of medical institutions throughout the country. So a couple of institutions have agreed and they have already implemented this pain-free concept. Not only palliative care, for any medical condition, if that patient is getting registered in that particular institution, they will be assessed based on the pain-free concept of the total pain, which you have heard earlier. That's the pain-free concept. These are the basic 5 objectives of the State Facilitation Division. This is the national presence of Palliative India. You can see the green portions are the work which we have done with the state governments, state drug controllers, or any other government agencies. Almost 25 states and 3 union territories till date. Then we have 5 sites of the palliative care training centers catalyzed as per the new norms. So like Trivandrum Institute of Palliative Science here as states, we have also catalyzed and supported palliative care center training centers in 4 other areas. Then we have conducted on-site foundation training in 10 sites. I'm not going into detail because there are a whole lot more details. We need another session for that. So just for you to understand how the palliative care delivery is happening in an Indian context. That's why we are doing this, trying to give a superficial knowledge for that. And coming to pain-free hospitals, as I told you, you can see one in Northeast Kacha Cancer Center in Assam and one in Dehradun. It's a cancer research center. You can see that small heart symbols. That's the pain-free hospital we have catalyzed with. We are trying to connect with all other institutions so that we could fill the hearts throughout the country. Next is the faculty development program. This is the UG curriculum program, which I spoke to you about earlier, to integrate palliative care in the MBBS curriculum. For the last 2 or 3 generations of doctors were not formally trained in palliative care. That's the major challenge we are facing on ground, and we need another next 2 generations of young doctors. They should be formally trained apart from the irrespective of their passion on doing something for the palliative care domain. They need to be trained formally within the MBBS curriculum. So we are in touch with the Medical Council of India and many civil societies for integrating specific palliative care module within the curriculum. Then palliative care centers catalyzed, I told you, 64 sites across the country. We have supported them end to end, starting from the infrastructure, getting the permission from government, applying for the opioid license, like RMI certificate, doing community mobilization. We will be helping them end-to-end for providing quality palliative care delivery. Hamrahi program is a connection with Palliative India and APLI, Australasian Palliative Link International. So they are an international experts in palliative care. So we have collaborated with Hamrahi program so that they can come here and share that international expertise, mentor the local partners on developing palliative care service within the institution. So both government and public and private sectors stakeholders are supporting Hamrahi program. We have it's a really successful program happening through the Association of Palliative India. Hands-on training sites, similarly, we have our doctors and nurses. This happened during COVID time. Doctors and nurses, those who are attending training virtually through Palliative India, they need hands-on exposure. So we have collaborated with local palliative care training partners across the country. We have around 40 sites, 40 palliative care hands-on training partners. Once you have completed the training, like you are attending this FCPC course, once you have completed this training program, in your region, you can identify our hands-on training partners. According to some eligibility mandates, we have selected these partners. You can go there, you can get a hands-on exposure directly. You can see for yourself what exactly is palliative care. The palliative care which we are talking about, that you can see for yourself. That's the hands-on training sites. Then the opioid accessibility. We conducted around 9 opioid availability workshop with the bureaucrats, with the state drug controllers, chief secretaries. Really, it's a bureaucratic thing. We conduct an opioid availability workshop. So teaching exactly what palliative care laws are in our system, in our country, to the lawmaking officials. That's a wonderful experience. So these are the basic understanding of the palliative care delivery in the Indian context. This is a standard audit tool. If you are running a palliative care service or if you are part of a palliative care institution, then this is basically for a self-evaluation, whether your program is going in the right path or not. So this audit tool have a 2-part. Part A is essential and part B is desirable. Essential is the basic required components of a palliative care service, and desirable is the ideal model of that. I think this learning material will be shared with you. So I'll stop here. As I said earlier, this is all very brief of palliative care delivery in Indian context. If you have more doubts, please feel free to contact us. All our numbers are shared in our website. I think we'll share in this chat box also. So contact us anytime. We'll help you in providing the any kind of palliative care support or advocacy within your region. So I'll hand out. Till now, we mentioned about the palliative care delivery model. Now the role of interdisciplinary team within the palliative care, I'll hand over to our social work team. Thank you.
Hello, everyone. So moving on to our next one. Am I audible?
Yes, Arathy, you are.
Yeah, okay. So moving on to the next is IDT, interdisciplinary team. And also along with that, I'm also giving a good direction towards what are the roles that being played by a social worker too. So that is also included in this session. And the first one will be interdisciplinary team. As the name suggests, it is the combination of a bunch of people who are working, who are willing to work for the patient and the care of the patient. So the explanation will be like interdisciplinary teamwork is a complex process in which different types of professionals work together to share expertise, knowledge, and skills to impact on patient care. So the center of everything is relied on the patient and the care of patients. So a bunch of professionals is needed for that, and we will be coming to that point in the later of this session. And second will be health professionals from different disciplines working collaboratively as a team. And you can see in this picture also, there will be volunteers included, doctors, nurses, social workers, and every kind of professionals who are related to this profession. And next, work in a coordinated fashion towards a common plan of care for the patient. So as I told you earlier, the utmost care, the quality of care to the patient is very important, and that is where interdisciplinary team is very important. So need of an IDT in palliative care. Why it is needed? It's because of these three things: disease-specific treatment, psychosocial, spiritual care, and symptom control. These two things means disease-specific treatment and symptom control can be done by the professionals. But the third one, psychosocial, spiritual care, it should be done not only by the social worker, it could be done with the help of a vast majority of people like volunteers, advocates, and all other medical professionals too. So this is the need of an IDT in palliative care. You can just see that everything is interconnected, and the center of the point is the care, the exact care that is given to the patient. Okay. So why interdisciplinary approach? No single expert can address the needs of a patient and the family. Every person has their own limitations. If you consider a doctor who is visiting a patient, he will only consider the physical conditions of the patient. He doesn't have the time to explore more about that patient at that time. So the pain and other physical symptoms can be addressed by that doctor. But later on stages, in that first video where Smriti Rana also shared some thoughts about the total pain. In that also, she said, it is not the pain of the physical health. It is the pain that is related to their mental status, their psychological status, their socioeconomic status also. So these kind of things are related to them. So this comes into the center like a total pain. So physical, like pain and other physical symptoms can be maintained by a healthcare professional, but the second aspects means the coming aspects like social, financial, psychological, and spiritual aspects can be observed, and a proper treatment or proper problem solving can be done with the help of an interdisciplinary approach. And healthcare professionals have a shared role in providing person-centered care. What are the benefits of IDT? First one will be a better possible outcomes achieved through collaborative approach. because we know that with a collaborative approach only, we can come to a point where what is the exact need of that patient. If it is related only to the physical condition, or it is related to the mental status or a socioeconomic status. Sometimes we may come to a position where the patient will be having physical pain, but more than that, they will be concerned about their family. So at that time, we don't know what exactly is going to happen. If the problem still persists, the pain still persists or not. We will be in a dilemma like, how can we solve this? We are giving so much medication and their pain is not really reducing. So at that time, with the help of an interdisciplinary approach, we can know about, with the collection of ideas or the information gathered from so much persons, could come to a point where we can come to an very problem solving approach there. So it is a collaborative approach, and then it improves the healthcare processes and levels of satisfaction of the patient too. Then it reduces the length of stay in hospitals and avoid duplication of assessments, because a doctor can make a psychosocial assessment because they have their own priorities, and that at the same time a social worker can be included in that process. And on the later stages, if any kind of advocacy needs are there, we can include a lawyer in that. So these kind of things means a collaborative approach, and duplication of assessments can be reduced with the IDT. Then more comprehensive and holistic records of care. Then share responsibilities and promote role interdependence. So the person should not be dependent on only one person. They can rely on so much persons for so much reasons, so and so. So then respect individual members' experience, expertise, and autonomy. So this will make a huge difference. Like every person's experience and their expertise will be very different, and they'll be having so much ideas, and we can make use of it for the care of patients. This will be the operational flow of an IDT. First, there will be a patient and family. Then an interdisciplinary team will be there. With the help of an interdisciplinary team only, we can come to a care plan, like in physical conditions, what can be done, in socioeconomic status, and that kind of problems, what could be done. And these kind of things can be done with the help of an interdisciplinary team. And after these three things only comes the outcomes. So moving to the next one is an interdisciplinary team within to provide total care. So these are the interdisciplinary team members in our context. You can just treat it like this program. I think FCPC, Foundation Course in Palliative Care, is also meant to be like participation of people from a wide variety of areas, like doctors, nurses, physiotherapists, non-medical clinicians, like medical social workers, counselors, psychologists, and allied health workers. And also I want to add one more thing, like advocates too, and then pharmacists, volunteers, palliative care assistants. In here, we call the down to earth, means the first person to meet that patient or the person is called palliative care assistants, and then administrators. So these are the, yes. Ida, do you have any queries? Okay, so these are the kind of persons who are included in an IDT. So these are not the only persons who are included. Anyone who can contribute in improving the quality of life of the patient and the family can also called as an IDT member. Okay. And we all know that everyone is not an expertise, means expert in so and so matters. And what we need is training. So that is where an FCPC session is actually meant for. All people, means all that professionals needs training. So these kind of training sessions are very useful for that, and make use of it. And moving on to the next is, who among the team is most important? This is a question for all of you. Like you can just chat in the box, or you can just unmute yourself and tell me, no problem. Who among the team is most important? Anyone? Anyone?
Everyone.
Yeah. Actually, that answer is exactly right. Everyone. We can't focus on only one person because it is an approach towards the care of the patient. So everyone, all of the above IDT members are equally important in the care of patient care. So moving on to the next will be the requirements for an IDT, interdisciplinary team, will be. First one is person-centered practice. The person will be the patient. So the patient will be the center of approach, means center of everything. And we have to create such an environment that he gets every care. And then next one will be a teamwork. Because sharing of ideas and sharing of what we obtained from the visits or what we collected from the phone calls, everything should be shared, and a teamwork makes a huge difference. And the next one will be communication. Without a proper communication, everything means nothing is possible, because you can consider me as a social worker. I'm a social worker too. And if I know about a person's illness, in the midnight, someone calls me and tells me like, today I'm having a very high pain. The very next day, I'm going to admit in a hospital. So could you please just inform the doctors or nurses? I don't have their numbers. Then I'll be like, okay, yeah, I get it. I'll inform them. Then all of a sudden, I'll just get into sleep. And the very next day, I'll just forget everything. The team doesn't know anything about that. And then all of a sudden, after 2 days, a nurse will be calling them like, how is you? How are you? What are you doing? How is going? And they will be telling like, I have informed the social worker about this and they haven't shared you anything. So a communication is very much important in an IDT approach. Okay, so these are the three things we require mostly. Then moving on to the next one is the role of a social worker in palliative care. This is like, till now we are speaking about a wide variety of people. Now we are going to speak, means I'm going to just discuss about only one person, like only a bunch of social workers. So what are the role a social worker plays in palliative care? It will be, the first one will be an assessment. First thing is making a rapport with the patient. I don't want to use the word patient, we don't call them as patients. We are recognizing them as persons, but in the session, means during this session, I'll just mention them by patient, okay? And first one is rapport building. Here you can see in this picture too, this is a beneficiary of ours, and he's having some health issues, and these are social workers and a nurse is sitting there, and you can see the face of the patient. He's always, means he's smiling to us, and with a good rapport building only, we can make use of that, and we can gather information from them. Like if we are being very rude to them, or we are just only talking to them, like only just getting information from them, they will not be like, I don't want to share any information. This is not what I want. I just want some compassion or empathy towards me. That will be everyone's case. So first thing will be a rapport building. Then with the help of an effective communication only, this could be done. And the next one will be psychosocial assessment. Psychosocial assessment will be, we do have a set of parameters for that, and we will discuss it in the later session. And next one will be conduct specialized home visits whenever necessary. In every cases, a phone call or a OP visit will not be very fruitful. So what we do is specialized home visits should be done to assess more about their situation. In some cases, the way to their home or the conditions in their house and all the socioeconomic conditions will be very weak. So we can't know about them, means we couldn't know me without seeing them. we couldn't get into a position where how they are living and what is their exact condition now. So that is where home visit is very appropriate. So that is what we do in Palliative India too. Once in a while, means in a week, we go to home visits and we conduct special home visits for that too. And the next one will be psychosocial assessment. In this one, this is a detailed one, so I'm not going very deep into that. And I'll just give you a simple example about this. Like first one will be the patient overview, like what are the diagnoses, when he get diagnosed with the disease, and what are the problems right now, where he's admitted, what is his medications and everything. Then next one will be the insight. What are the insight means what the patient knows about the disease, and if it is going for a very long period or not. Does they know about the urgency or the seriousness of the disease or not? So these kind of things could be included in insight. The next one will be the family overview. It will be denoted by genograms. Genograms means the pictorial representation of the family tree. You can usually call it as a family tree also. With the help of a proper family tree, we can know about the basic details and every details about the family. Like we can extend the genogram into the extended family to like their three. Yes. Okay. I think someone is unmuted. Yeah. Okay. So with the help of a genogram, we can get into more details about families. And then next one will be socio-economic assessment with the help of ecomaps. Ecomaps means what are their current situation, like what are the helps they are getting from any other sources with their family or within their extended family, or with the help of any organization they are getting anything or not. So we can know about it. In Kerala, we will be, means we get information from the from ration cards. Here we categorize the people from like poor, very poor, middle, and high income categories. So with the help of that, with the proper assessment, we can know about what are the exact socioeconomic status of them right now. And then psychological assessment, like what are they going through right now? Have the disease affected their daily living, or the education, or the daily living is affected by that, and it is how it is affecting them psychologically or not. So these kind of things can be assessed in psychological assessment. So we have a proper tool for that. Okay, so I don't want to discuss more about that. We can have it on later sessions. And rehabilitation assessment. In some cases, we have to do some rehabilitation works for them with the help of community. We can mobilize some any kind of resources for them. And then will be spiritual overview. In this case, spiritual overview, it needs more and more sessions with them. And then only we can get into that, because it's a huge area to cover. And this will be done with a very long time. This will take more time. So this will be the psychosocial assessment aspect. Then the next one will be what we do in palliative care is, first one will be advocate patients' rights. Let's know about their rights, if they are getting any government schemes, or if they are allocating any kind of pensions or anything. These kind of things, they don't know about it. So we have to educate them first. We have to just give them details about you can get these kind of things, and you have to go there, and you have to fill in this form and everything. So first one will be advocate, like patient rights and needs. Then the next one will be educate about their medical diagnosis, their prognosis, like what is going on now and what will be coming. These kind of things can be educated to them. Then the next one will be facilitate. With a proper mobilization from community, we can facilitate resources, and we can make them to come across opportunities. With the help of that, they can just improve their quality of life. Okay, so this is the patient navigation. Next one will be, our role is mobilizer or networker. This is also the same as the previous one. Like first one will be PIE, person in environment approach. Like I'm not in an environment like you. You'll not be in an environment like me. Everyone have their own environment. So we have to be very clear about that environment, and we have to visit them frequently, and we have to know about everything. Then only we can mobilize something for them. And then the next one will be liaising the government and other non-governmental agencies with them, with collaboration with them, like government schemes and financial assistance from them. What happens in patient care is, if a patient have cancer, they don't know about the cancer pension, or they don't know about how it can be done, or what are the formalities for that. So these kind of things can be mobilized with the help of a social worker. That's what we do. Then connect with the healthcare system, emergency medical support. We will give them guidance, because we are not professional to give them give the exact care at the right time, but we will be a connecting point to them whenever they need it. So these are the things we do, we mobilize. The next one will be the center will be psychosocial support. These are the connecting factors. First one will be counseling. If there is any counseling needed, we will just recommend them to any other health professionals, or if we have that kind of resource here, then we will just facilitate it. Then the next one will be rehabilitation. We have already talked about that. Then vocational things, like if they need any kind of vocational rehab support, like a small shop or any kind of business starting. So these kind of things can be helped. Then educational support. Sometimes what happens is the illness will be affected, will get affect the children's mostly, because their education is very more or less stopped, and they will not find any kind of support from any other family members too. So in this situation, we can get help from the society, and we just mobilize it to the children's too. Then next one will be bereavement support. After the death of the patient, we will call them frequently. Like whenever is needed, we will call them frequently, and we have some supporting groups here. It's called ONAV, and it's a forum for them to talk to each other, and we will just we'll be the moderator for that, and we'll have some programs for them, and if a visit is needed for them, we will do it. So these are the things in accordance with bereavement support. Then next one will be practical or financial support. What can be done in their financial aspects that can be done with this. And then the last one will be training. It will come in rehab and vocational too. Like we will train them to make some goods or something, like some products, umbrella making, pen making, and everything. We will give them guidance, or we'll get the help from professional, and we'll just educate them with the help of them. So these are the things that comes under psychosocial support. Then next one, I don't want to go very brief, will be rehabilitation, like provision of basic amenities like food, shelter, water, sanitation, etc. With the help of community mobilization, we will help them to, like these are the basic amenities. So we have to help them to achieve that with the help of a proper investigation only. And then next one will be vocational rehabilitation. Like you can see in these pictures, they are making some kind of goat reading and making of flowers, making of jewels, etc. So these kind of things can be supported with us, with the help of us. Then education support is the next one, and other necessary aids based on assessment like travel, surgery, house modification, etc. This can be done. Then next one is psychological support, like providing a space to vent out, being available for the patient and family whenever it's possible, and then linking the patient and families to government schemes and services, resource mobilization from the community. Then conducting community awareness programs like this, and coordinating trainings for volunteers. So with proper education only, a person or society knows about what is going to happen, and how things can be done in a palliative care. And so there are a lot of stigma, so we have to eradicate it. So with that's why we do training sessions too, and then conducting recreational events for patients and families. This have been done in Palliative India over the previous year. So these kind of programs also done with the help of us. And so these are the things, these are the roles of a social worker we do in Palliative India. So if you have any doubts, you can just note it in the chat box, or maybe we'll be very free to answer it. So I think we have a case presentation is coming up. So I have taken 10 minutes extra time, so we just move on to the next. Thank you so much for listening, and this is the last note for you. Just go through it.
Thank you, Sharat. Thank you so much. Am I audible?
Yes, Manishi, you are.
Okay. So if anybody has any questions regarding the things that Ms. Arathy, Vishnu, or Sharat has discussed, please do put it up in the chat box. Since there's a lack of time, we'll go on with the case presentation for now. And afterwards, if there's any question, then we can look into the chat box and work on it. Deepa, please go on with the case presentation.
Hi all. This is a case of a patient who's registered with us through telehealth. He is 70 years old, a male boy kid. He is diagnosed with hypoxic ischemic encephalopathy, or Lennox-Gastaut syndrome, LGL. It is this information actually we have collected from the SIT records. So, next slide. Going to the medical history, as I said, he was diagnosed with so-and-so. Since birth, actually he is suffering from this illness. During birth, they found that the cord around neck, anterior furniture depressed, birth asphyxia, hypoxic ischemic encephalopathy, developed multiple episodes of seizure. There are interventions took place during the birth, and somehow through the physiotherapy, as per the informant, they said there are slight changes seen in the boy, and he is completely bedbound. His food intake is low. He's taking actually a very low amount of food, and for the family, they are taking 2 to 3 hours to feed him. He weighs only 6.5 kg. He's of 7 years old now. And currently he is getting treatment from SIT, Trivandrum. Patient inside. Actually, it is quite difficult as he's just a 7-year-old boy and he cannot speak. He's bedbounded and no information about anything else. So it is very difficult to analyze all these parts like diagnosis or prognosis or palliative care. So it is clearly, I think all clear about this thing. It is very difficult to analyze actually. So while asking to the family, they know what he is going through as per the doctors that they've informed them. So they know that what he's going through, and this prognosis, actually, they are not that much cleared about, but they know that these are the treatment and that can be given to their boy. Or life expectancy, I don't know how much they are clear about it. Then palliative care information, they know that this is a service being given for the bedbound people. So we have given them information about that, and after that they said, okay, they are kind of informative about all these things. Next slide. So this is the family genogram. So you can refer the legends as well. So this family has parents and their mother's parents as well, and
She already had a miscarriage. Her first child was a miscarriage, and then now they have this 13-year-old and 10-year-old and this 7-year-old boy in the family. Those grandparents have their own old age issues, and this partially marked mother of this patient, she has suspected psychiatric issues. Obviously, it might be because of she's going through all this pain since birth. She's seeing him as like this, and she already had a miscarriage. All these factors is actually contributing to this psychological pain, actually. And the only one that actually supports them is Mrs. E, who's a sister, younger sister of his father. And though she's not that supportive, but she comes and see how the kid is, and if there is information or if there is any little amount of money they can give, the supports the family like that. She also has small kids of, so you can see that 6th or 4th or 2nd class or even KG standard student, children she has. So her husband is also not that good in earning finance, so it is very difficult for them to support this family as well. So next slide. Mr. J, that means child's father, has a stressful relationship with his siblings except Mrs. E, which is younger sister of him. Due to that, he had to build a house on the ancestral property by taking a loan. Even though the extended family would inquire about the status of the child, his father managed to get a visa to work in the UAE, but he couldn't continue his job as his wife developed psychological disturbances as a result of his absence, as well as dealing with the illness of the child by herself alone. As reported by the informant, she talks to herself, hearing strange voices that might be auditory hallucinations, poor sleeping pattern, sad mood, and not performing well in household activities, as well as in taking care of the other 2 kids. Elder child in the family is about 12 years of age, and he is trying hard to help his mother in taking care of his brother. The middle child, who's a 10-year-old, she doesn't actually know how to take care of these struggles and to how to move on. She just comes and sits with her books, and she doesn't know what to do after hearing noises from her elder and younger brother. She actually don't know what to do. Grandparents are getting old age pension, solely support in the family. And this is the sole income of the family. However, the father is trying, now he's trying to move by looking for a good job somewhere. Next slide. So this is the echo map. Echo map is how the patient is connected with the surroundings. So here you can see that the patient and his family has a strong bond between aunt A, patient's aunt A. She's the only one person supports them well in that family, in the extended family. So by religious ways, it's a tense relationship. Like they are not getting that much support, but somehow they feel like, okay, I'll go to the mosque and pray likewise. And from the school of patient siblings, a positive response, a positive support they are getting by reducing the fee and all. And this extended family gives a stressful situation to the patient as well as the whole family, because they are very concerned about the ancestral property they have. There are so many issues related to that. And SAT is, of course, where the child is getting treatment right now, which is a positive support for them. And there are fathers, patients' fathers' friends who's supporting, not completely, but they are getting a positive support from the friends as well. Next, please. So their socioeconomic overview is like they live in a partially completed 2 BHK terraced house. He has taken a loan for this from a private bank. And it was actually necessary for them to move out from the ancestral house because there were issues happening. He took this loan because he was already got a visa to Gulf, but as I said, he discontinued it because of his wife's psychological status. The primary and sole breadwinner is his father by doing a coolie job right now. Their ration card is BPL of pink color, where they get only rice or wheat, like that, I think. And thus they get this thing. So other food needs, like this baby can be fed only baby meals. Baby supplies only can be given for this baby. Other things like grains or vegetables or whatever we need for daily cooking and all, I think they are not need to eat. So, and the grandparents are getting old age pension, which is the only one income in their family now. There is no other financial support from anyone else. As I said, his father was in Gulf and he quit his job. Other ill members of the family, as I said before, that the old age issues in the grandparents and even mother's psychological status is not being reviewed with anyone else because of the financial crisis they face now. The treatment expenses are high, especially the medicine that are not available in SAT. SAT provides free medicines, but there are medicines that they have to buy from outside, which costs rupees 500 a month. Educational expenses of, excuse me, sorry.
Deepa, please continue.
Okay, so this educational expenses of other siblings are getting high because they are going to the higher standards. Moving, next slide, please. So psychological overview, it is actually not possible. As I said, it is the patient registered through telehealth. So reviewing their mental status is not that easy. But as according to the family, he just cries, and whenever he's hungry, he shows some lip movements, and there is nothing else. Sometimes he shows kind of irritable behavior. So that is it. Next slide, please. So total pain as physical aspect, it is of course the movement because he's bedbound, and ADL impact, the cognitive impairment is there, and it is a life-threatening disease. So the family is concerned about it, multi-organ dysfunction, etc. And psychological disturbances that causing the total pain for the family are behavioral issues of the child, irritability and crying spells of the patient, deprived mother's psychological well-being, neglected parenting for elders. Elder children, they are not getting that care from their mother as well as the father because they are busy dealing with all these things, and the mother is in a side with the psychological issues. So socioeconomic issues like separated from other family members, acceptance of the society is very low. They don't even come and see as the disfigurement might be a reason for them to accept all these things. Then the financial crisis, as I said, there is no job, loan, education, and treatment, etc., causing high pain to the family. And other ill members are also causing the total pain. Then the spiritual, it is a declined faith in life. Of course, it is there. No support from religion. As I told you, Sitchinus support. There is a partial support. As like, oh, okay, it is like that. I prayed for it. These are the words. And the future hope. What will be the future of this family? Especially the child. Then these are the discussion points. Like family's primary concern is the survival of our patient. How far it is possible. mother's psychological recovery or well-being to support our patient, meeting financial expenses, how they meet this education loan. I mean, the baby needs diapers for 4 to 6 diapers he needs in a day. Then there is no sufficient food. Then the psychosocial supports for the family, like how we provide the social support, I mean, social aspects, occupation, then extended family support. Of course, they need it, but they're in a crisis now. Then the coping skills, how the father or the mother or the grandparents or even the other children, how they will cope with the situation. Then their interest, abilities, where they are getting enough entertainment, especially when the children, I mean, the elder one, whether they are getting it or not, what are their abilities, where it has gone. Then the patient depends only on baby foods, they are facing a lot of feeding issues. The mother is sitting like, she is not even getting a sleep because in between he's waking and is, hungry for food, and she's taking 2 to 3 hours to feed this baby. So if there is anything can cater the need, then the point is vocational rehabilitation for the mother or anyone else in the family, however it is possible. Then the quality of life of a patient. Is there a chance of going to coma stage? As actually, when we discussed it with the nurse, okay, there are chances of going to a coma stage, whether it is, it will happen or not. So these are the discussion points regarding this case. So.
Thank you, Deepa. Thank you for that wonderful presentation. Manisha?
Yes. Deepa, if you could go to the previous slide and keep the slide on.
Sure.
And if anybody has any comments on these discussion points, please do feel free to unmute your mics and speak up.
Yeah, I had a question.
Yes, please.
Yeah, I think I put it on the chat also. Like, what's your success rate outside of Kerala? Because I'm just amazed to see the community support and how easily people come together. But I'm a bit skeptical since I come from Bombay. It's a cosmopolitan city, different cultures coming together and all that. So how easy it is to mobilize community support in a place like where different cultures, different language people are coming in, and people don't have the unity which Kerala is kind of famous for. So can you please answer that?
Vishnu and Arathy, could you please step in and speak?
Yeah, thank you, Manisha. Hope you can see me. Yeah. So thank you, Mr. Abhijit, for asking that. You are true. Kerala is far better than any of these states compared to palliative care delivery, especially on community mobilization and volunteer mobilization part. But we don't see Kerala being an average Kerala. I don't think Kerala model is the best model. We say that we always do suggest that community-based palliative care model is the best. So there are cultural contexts, there are social contexts which decide all these things. But especially in Maharashtra, we have very good community mobilization. It's been done very good by one of the palliative care stakeholders there. Hope you have heard about Snehachal. It's in Nagpur. I think Sunanda is here.
Yes, I'm here.
Okay. So Sunanda, I think you met her during the last session. She's one of the regional coordinator. She's handled the center region. So in Maharashtra specifically, Snehachal have a great track record on mobilizing the community. Similarly, if you can, like if you are from any other region, any of the states, if you can arrange a session with the community or the volunteers, we can offer, Palliative India can offer a free of cost training program, more kind of an orientation program for the community. What exactly is the role of community there in mobilizing the palliative care beneficiaries, whether they are patients or the caregivers? That kind of orientation can be done, an on-site or a virtual program. Sunanda can coordinate that for you. And from that, that's the initial step. And from that program, if it is a 30 or 50 participant count program, still we'll have a 2 or 3 local champions from within the community who is really interested to contribute back to the community. With that, selecting them as the local champion, we can start the palliative care delivery within that community. So this is a gradual process. Kerala, of course, has the many social, context-wise, cultural-wise, Kerala has many advantages in that part. But I won't say it's impossible, but it's not that easy. But it's a gradual process. We can help you out there anywhere. We have very good model with Snehachal in Sangwari in Chhattisgarh. There are in a couple of stakeholders in Northeast. There are models, but all of them are really scattered. So we cannot generalize Kerala as the best model, but we are ready to support. You can get in touch with Sunanda, correspondent.
Right.
Thank you.
Thank you. Thank you so
So
much.
I just want to add a few points.
Sure, Sunanda.
Since he's referring to Mumbai, so I would like to tell here that we have a network in Mumbai. So it is consisting of all the organizations, who are working in palliative care. So we are trying to address to this issue which is right, that we have diverse cultural things in Mumbai. So we're trying to do it, and I'll just get in touch with that network, and I'll update the team who wants to know about Mumbai, what's happening in Mumbai. Okay, I think Mr. Arvind, is it? Sorry, what's your name, sir?
Abhijit.
Abhijit. I think I've dropped you an email, so I'll be in touch.
Yeah. Yes, please. Yes, please. I'll be eager. Yeah. Thank you. I'm eager.
Thank you.
Can we stop the share screen, please?
Yeah, I was about to say that. Thank you for that, Abhijit. Yeah, if there's any questions from any others, we can proceed with that, or else we can wind up the session.
So,
Thank you everyone once again for joining us today. And I hope we've talked about a lot of things today, including the delivery of palliative care.
Manisha, hello. I think Manisha has lost her connection. Let's wind up the session. I've shared the feedback link with all of you. Kindly go through it. And if you have further doubts, you can add it on the WhatsApp group. And if any other doubts, you can contact our national coordinator or regional coordinators. The numbers are already provided in the WhatsApp group itself. Thank you all for being here with us today. We'll see you on the next class. Bye.
Thank you so much.
Thank you so much.